And now we are beginning one of our favorite parts of our show. And this is where we have one of our residents introduce a topic where we have a patient come and discuss the disease. And our resident is Dr. Alastair Williams, who is a hematology resident who I have re-met this meeting. And he did his undergraduate at University of Toronto, and there's not a lot about him online that I could poach to discuss with you today. But what I have heard from a lot of people is that he is a rising star in hematology. So what I learned about him today is that he is an avid skier and biker, road biker, and a real outdoorsman. That's what he told me. And what he's going to talk about today is immune thrombocytopenic purpura, setting the stage for our next speaker, an interesting patient who's going to tell us a little bit about her life. So thank you very much for joining us, Alastair.
Thanks for that very kind introduction, Dr. Prysdale. It's a bit of a tall order talking after Dr. Scholzberg, let alone trying to condense ITP into 6 minutes, but I'll do my best. And then, of course, we have Melina talking afterwards on her perspective with the disease as well. So I'm hoping we heard from Dr. Lambert earlier about ITP more from a pediatric standpoint. I see and treat adult patients, so this is going to be more from the adult side, as well as with a little bit of a focus on what the treatment is and the treatment landscape in BC in particular. So just to take us back to the definition, because I know not all of you are clinicians, so the definition of ITP is that it is an autoimmune disease characterized by isolated thrombocytopenia, platelets less than 100, although it can be seen in coexistence with other hematologic diseases as well. And in the adult world, we usually characterize it as either being primary, in which no other inciting factor is found, but it can also be secondary to a variety of other underlying diseases which disrupt immune homeostasis, and I've listed some of them here. You've heard about viral and bacterial infections, vaccination, other autoimmune conditions like lupus, immunodeficiencies. We heard about CVID, ALPS, and then, of course, in the adults, we also see a lot in association with malignancies like CLL, other lymphoproliferative diseases as well. So this is how we kind of go about thinking about ITP. And I know you've seen this diagram before. This is from the review published in the New England Journal just a few years ago. Essentially, the postulated mechanism for ITP is the production of antiplatelet antibodies targeting platelet glycoprotein 2B3A and other platelet glycoproteins, which causes opsonization and then phagocytosis by macrophages in the spleen and to a lesser extent in the liver. Although we more increasingly recognize that there is an component of impaired production as well, that these antibodies can impair megakaryopoiesis and impair the platelet release from megakaryocytes within the bone marrow. Associated with this is a disruption in immune homeostasis with a shift away from a Treg phenotype to a more Th1, Th17 cells. And of course, our understanding of the disease continues to evolve as time goes on. A few little tidbits about the disease. A lot of patients can be asymptomatic when they first come to you, and they may just be referred for an incidental finding on their complete blood count, and that can be anywhere from 1/5 to 1/3 of patients. And usually these patients tolerate very low platelet counts quite well, in contrast to some of our other thrombocytopenic disorders like bone marrow failures, leukemias, and such. And usually the bleeding symptoms don't tend to manifest until the platelet count is under 20, with the most common symptoms usually being mucocutaneous bleeding, petechiae and purpura, and then, of course, as Dr. Scholzberg spoke about in a slightly different context, but applicable here as well, heavy menstrual bleeding. So it can be quite bothersome to patients. The annual incidence of ITP in the U.S. is estimated about 3.3 per 100,000 per year. And of course, we don't have population-level data specifically for BC, but expected to be about 200 cases diagnosed in adults in the province per year. And of course, it is a chronic disease. Mortality is low, but morbidity is high. So the incidence, prevalence greatly exceeds incidence at approximately 12 per 100,000. And you can see how the prevalence certainly increases with age. There is a female predominance at the younger ages, but in the age of 60 plus, as you get into the more elderly population, actually men tend to be diagnosed at an equal frequency of women. So when we're thinking about approaching a patient who we have a new diagnosis of ITP, I just want to give you a little bit of overview of the treatment. About 10 to 20% of patients will go into a spontaneous remission, and we don't really know why. It's hard to predict. But the others will need some sort of first-line therapy. So when we think about treatments for ITP, what are our options? So we can either think about it simplistically as increasing production, and I've put a little bone marrow there just to talk about where platelets are produced. Unfortunately, we have limited options for this. The main workhorses are what are called our thrombopoietin receptor agonists, somewhat newer drugs, although we've had access to them for a few years now. So L-thrombopeg, avatrombopeg, which are oral, and then romiplastin, which is subcutaneous. If you think about it, it doesn't really make sense if you're just increasing production. I mean, I can transfuse a patient with ITP platelets and they won't increment their platelet count. So why is increasing production for them and just giving them more platelets, in a sense, working for them? And it's postulated that there are some immunomodulatory effects of these drugs beyond just simply increasing platelet production. And of course, we did hear earlier about the interactions between megakaryocytes and the immune system, so there may be some relevance of that here as well. But we have many more options for decreasing platelet destruction, and I put the spleen here because that's where most commonly we think of platelet destruction in this disease occurring. So the oldest, I would say, options for us are kind of the workhorses, corticosteroids, and then intravenous immunoglobulin. Other options, there's rituximab, which is an anti-CD20 monoclonal antibody. We have more what we call traditional immunosuppressants, things like mycophenolate, azathioprine, cyclosporin. Fostamatinib is a newer medication, not as frequently used, but it's a spleen tyrosine kinase inhibitor, so really inhibiting macrophage phagocytosis. And then a good option actually for a lot of patients is a splenectomy. If you remove the organ that is removing most of your platelets, then can be effective for controlling the disease. So let's just simplify this a bit. If we take that off and then go back to our new diagnosis of ITP, for patients needing first-line therapy, we can reshuffle this around a little bit, and we stick our corticosteroids and our IVIG up as first-line therapy. And then we reserve these other ones down here as possible second-line options. So first-line therapy can be effective for about 30 to 50% of patients in controlling the disease in the long term and keeping them stable. But others may require second-line therapy. And then what are the comparative efficacies of these agents? So TPO receptor agonists actually are very good. Overall response is about 75%. And if you stay on these medications, the sustained response can be about 65%. There's about a quarter of patients who can actually come off these medications and maintain their platelet counts up, which is quite remarkable. Rituximab, so good initial response, but if you're not continuously dosing it because it is kind of a one-time series of IV infusions and then you follow them from there, the response tends to fall off at 40% at 1 year and then 20% at 5 years. Immunosuppressants are quite variable, kind of quote about 50%, but again, as older medications, they haven't really been well studied in a prospective manner. And then splenectomy, even though it is a surgery and with the attendant risks of that, it actually has fairly good long-term disease control with a sustained response of 60%. Unfortunately, in BC, we are somewhat limited with the access to things like thrombopoietin receptor agonists because they are very expensive medications. And then rituximab as well, it is less expensive, but also the logistics of arranging for IV infusion. So oftentimes we're left with treating patients with immunosuppressants. Some patients with stable disease will progress to requiring second-line treatment at some point. And unfortunately, a lot of patients who get second-line therapy will ultimately relapse and require additional corticosteroids or IVIG with their attendant risks, as Melina will discuss. But things with IVIG in particular are things like aseptic meningitis, the thrombotic risk. It can cause acute kidney injury, of course, infusion reactions and other allergic reactions. So these are not benign interventions that we're proposing when we're under-treating or inadequately treating our patients with this disease. So this takes me to the last point, which is quality of life. And in Canada, what I would say is that most patients receive first, second-line therapy with either immunosuppressives or splenectomy due to the limited access to rituximab and TPO-RAs. And unfortunately, this does lead to discrepancies in published guidelines. So the American Society of Hematology and the International Consensus recommendations do recommend TPO receptor agonists, rituximab, and then splenectomy as the recommended second-line treatments, not other immunosuppressives. So there is that discrepancy in practice that we have. This was the Immune Thrombocytopenia World Impact Survey, or IWISH, which actually demonstrated that in contrast to what we think as a lot of the impact on patients, which is bleeding and bruising and these symptoms associated with the objectively low platelet count, a lot of patients, as you can see up there on the severe side, which is on the right, report fatigue, anxiety about their platelet count, and depression, things we don't often think about when we're just looking at a platelet count and deciding whether a patient is stable and whether they need additional treatment or not. So I think there is a substantial morbidity beyond just the quantitative platelet count and the bleeding that happens not only because of the platelet count itself, but because of the treatments that we're exposing patients to and the adverse events that can result from that. So just to summarize, ITP, as we discussed, is an autoimmune disease that presents with thrombocytopenia, which may be asymptomatic or symptomatic. In those who are symptomatic, there are issues with bleeding and bruising, but also fatigue and the side effects of treatment. Access to guideline-recommended second-line therapies in BC and in Canada more generally does remain limited, which can lead to recurrent courses of steroids and or IVIG and associated complications. And all of which is to illustrate, as I think we've learned, at least at this point of the talk today, that not all classical hematologic diseases are benign, and hence the reason we're moving away from the use of the term benign hematology when things like ITP, heavy menstrual bleeding, and others have such a heavy impact on the patients we see on a day-to-day basis. So thank you very much.
Hugh?
Hi, thank you for your talk. A question about a splenectomy. What are the surgical considerations for operating on patients who are very thrombocytopenic in the event that splenectomy is deemed to be the option?
Yeah, that's really good. I mean, I'm not a surgeon, but oftentimes these procedures can be done laparoscopically and minimally invasive. Generally, the surgeons who do this are comfortable operating at very low platelet counts with the understanding that patients with ITP often don't really bleed, and their platelet count doesn't necessarily reflect their true thrombotic or their ability to clot after the surgery. But we support our surgical colleagues as we can in treating them before with things like shorter courses of corticosteroids or IVIG as necessary to get the platelet count. If we need to give platelet transfusions during the surgery just to provide that little bit of a boost, we can. But I think we're really fortunate here that the patients who we refer for splenectomy, the surgeons tend to be very understanding and comfortable with these lower platelet counts.
Thank you.
Big applause, please.